Hello, everyone, and welcome to the first of 4 lectures for the Coronal Polishing course. In this first lecture, we are going to talk about the indications and contraindications for coronal polishing. Sure. Here we go. Maybe. There we go. All right. So from the Ohio State Dental Board, there is a laundry list of objectives that we have to cover in order to make you well-rounded and ready to provide coronal polishing safely and effectively to your patients. And so you can feel free to look through all of these, but the general thing is just noticing that there is lots of variety of different topics that we will be covering, and we will make sure that we get all of those covered as part of the course through these 4 lectures. And then we will review a little bit during your lab course, the lab portion of your course, and then we will be practicing on each other during the clinical portion. And then we will evaluate your level of knowledge within the quiz that we will be completing at the end of your in-person session. So first, we're going to talk about the contraindications to coronal polishing. So as it pertains to patients' medical histories. So as dental professionals, all of us should be practicing reviewing patients' medical history during all of their appointments. And so it's really important that we all take ownership of that, especially because sometimes it's the assistants bringing the patient back, it's the doctor bringing the patient back, it's the hygienist, whomever it is. We just really need to take the ownership of reviewing that medical history. So as it pertains to coronal polishing, there are a few things that we can identify on the medical history that would prevent us from doing the coronal polishing procedure. So first is communicable diseases. So what that means is it is any disease that a patient may have that could be spread with aerosols. So we are all probably super aware of what aerosol generating procedures are, since we just went through the COVID pandemic, and it was probably drilled into all of our heads. So, but just as a reminder, aerosols are little droplets of either liquid or particle in the air that can travel through the air. And so aerosol generating procedures are anything that would cause those to occur. So coronal polishing is an aerosol generating procedure, but some other things that we do in the dental office include anything that we do with a handpiece. So that is like when you're drilling on a tooth, or you're finishing and polishing a restoration or anything like that. Or when hygienists or dentists are using the Cavitron, that is also an aerosol generating procedure. So several different things in the dental field that could be aerosol generating, which would cause the potential for disease to be spread. So if your patient has any type of communicable disease, then we would want to avoid any of those aerosol generating procedures. Respiratory problems is the next thing. So like severe asthma or COPD or emphysema, just because your patient has one of those things does not necessarily mean that you wouldn't be able to coronal polish. But if they're having a really bad day with coughing or wheezing, or if the air quality outside is really bad, or for whatever reason, they're just having a really bad lung day, then that might be, a reason to postpone aerosol generating procedures like coronal polishing for those types of patients. The next one is patients at risk for bacteremia. And so that is when bacteria in the mouth is introduced into the bloodstream. And so we might not necessarily think of coronal polishing being something that might induce bleeding, but in fact, it could be. So as we'll discuss when we're talking about the specific technique that we're going to use for coronal polishing, we're really working right along the gingival margin. And the technique that we're going to share with you is a technique that will hopefully prevent, bleeding and all of that. However, we have some patients that, might have severe inflammation, gingivitis, and things like that, that you almost like look at it and it starts bleeding. So especially in those patients, you just have to be mindful. And if they're at risk for bacteremia, or if they've had a previous history of that, then you would want to forego coronal polishing. And then, sorry if you can see my little bar there, if that's blocking the slide, but the other thing would be is if the patient has an allergy to any of the polishing products. And so, we have all of those yummy flavors inside the in the dental office for the different polishing pastes, but some of those might have artificial flavorings, and that might be something that patients might be allergic to. Potentially some dyes, or even the prophy angle itself, the head might have latex in it, and so you can certainly get latex-free prophy angles, but you would just have to, search that out. Not all of them are latex-free, so be mindful of that if you do have patients that have a latex allergy. All right, so we'll talk a little bit more about patients that might be more susceptible to getting a bacterial infection, because those patients we would want to potentially do a pre-med. And so you might have heard about this, with other patients that you have been participating in their care for, about needing a pre-med. And so this list, the majority of them are like always pre-med patients. And so if they've had any of these, then they're going to be having a pre-med for life during any of their dental visits. That last one we'll talk about a little bit here in just a minute. But anybody who has had a surgery to have an artificial heart valve, they would need a pre-med for life. Anybody that has had a previous history of endocarditis, so an infection in the heart, they would need a pre-med. Complex cyanotic congenital heart defect. So congenital meaning the patient was born with it. So if they have a congenital heart defect, that would require pre-med. If they've had that congenital heart defect repaired and it's been in that first 6 months following surgery, they would also need a pre-med. But this would be terrible, if you had your heart repaired and then there was like a residual issue, then you would need to continue to be pre-medded for life. So I couldn't imagine going through, heart surgery and thinking that you had everything fixed and then there still being a problem. So that would be unfortunate for your patient. But those patients, if they were still having residual effects, then they would need to be pre-medded. Someone who had a heart transplant, but again had like a valve dysfunction. So again, now we're having another different type of heart, in this case, a whole heart transplant, but one of the valves is not working properly. And so they would need a pre-med. And then finally, anybody who has had shunts placed or conduits. So these are things that might just help the flow of fluid. And so those people would be at a higher risk for a bacterial infection. So we would want to provide them a pre-med. As far as joint replacements go, so this has been kind of one of those things that goes back and forth, back and forth. But as of like the last several years, it has not been a requirement for patients who have simply had a joint replacement to be pre-medicated. And so we always err on the side of caution. And if the physician or the surgeon requires, or requests that they have a pre-med, then we will, of course, follow their recommendations. But it is not like a hard and fast, everybody who's had a joint replacement needs a pre-med. That is, in fact, actually not true at this current time. So that kind of brings me to the point that you just always want to be paying attention to the updates that come out, for all kinds of things, but in particular about when pre-meds. I've not seen, these top few ever change, but that joint replacement one for sure has kind of gone back and forth, over the years. So. Okay, so if your patient does require a pre-med, then they would also be patients that would maybe be immunocompromised. So that would be anybody who has HIV, autoimmune diseases. Oftentimes, they'll be prescribed medications that like lower their immune system so that it's not like fighting against itself quite as much. Patients that have had uncontrolled diabetes, often, cancer treatments that lowers patients' immune system, and so they would be more compromised in this situation. So you'd want them to be pre-medded. Patients who are going through dialysis or have had a transplant, and then also some blood disorders like hemophilia, excuse me, or sickle cell anemia. So those you might just have a conversation with their doctor. Do you want me to want my patient to be on a pre-med or not? It might be how severe is their case currently? What level of treatment are they at? Have they had their transplant yet or not? Has it been a certain amount of time post-transplant? So these are not in the always list. These are in the let me contact your physician and just have a conversation about whether or not they find it to be necessary. Okay, so if your patient does require a pre-med, then you will need to know, what is the recommended regimen for that pre-med in case it's up to your doctor or you guys to, write that prescription. Obviously, that's not necessarily on us. It would be on the doctor to write the prescription, but it's still an important piece of information that you would want to know. And so the antibiotic needs to be taken 30 minutes prior to the event that you're going to be doing. So in this case, coronal polishing. I remember we would have patients show up and they would forget to take their pre-med. And if they did not have a penicillin allergy, then we would have the antibiotic on hand that we'd be able to give to them. And by the time it was needed for them to have it in their system, then it was usually fine. And so your office might also have antibiotics on hand to give. But if your patient does not have a penicillin allergy and they are an adult, then the regimen is 2 grams of amoxicillin. That's the medication of choice. And then for children, it's 50 milligrams per kilogram. So you'd have to know how much they weighed, and you'd kind of have to do a little bit of math. For the penicillin allergy, that was clindamycin for a really long time, but that is no longer recommended as of 2022, so fairly recently. And now it is cephalexin. And the nice thing about that is it's the same like regimen for that type of medication as the amoxicillin, so 2 grams. So that makes it a little bit easier to remember. So 2 grams for adults and 50 milligrams per kilogram for children. So I like it when it's easy to remember. You need to remember a new medication name, but at least the dosing is the same. Okay, so those would be, some contraindications or, things that we need to modify in order to be able to complete our coronal polishing. But now let's talk about like why or what are the indications for coronal polishing? Why would we be doing this procedure? So it's important to note that this should be completed after scaling. So you want to remove all of the calculus prior to coronal polishing because coronal polishing is not going to remove the calculus. And that needs to be removed as part of the cleaning appointment. So we're really just cosmetically removing any biofilm and extrinsic staining. And we're going to talk all about the types of biofilm that you can find and also the types of stain throughout this lecture. So it's important to note that this really is just improving the aesthetics and the appearance of the teeth. So, everybody wants their teeth to feel smooth. They want their teeth to look pretty. They want their teeth to be white. And so coronal polishing can help with some of that and can kind of, it's like the icing on top of the cake, at the end of the cleaning appointment. So it's really cosmetic. Coronal polishing is not therapeutic. So it's not used to fix a health problem or to treat any kind of disease because stain does not contribute to inflammation of the tissues or decay. Okay. Also wanted to bring to your attention, anytime when I have things like underlined or bold, you should pay special attention to that because it's important for the care of your patient. But also you might see it pop up on a quiz. So we'll take a couple minutes just to review some of the anatomy of the tooth, and hopefully this feels familiar to you, generally speaking, maybe not all of the specifics as far as like the 98% of inorganic or mineralized material, but hopefully the layers of the tooth is, super familiar to you. So the outer layer of the crown portion of the tooth is, of course, enamel. And we know that it is extremely hard. And what that is telling us is that it has a lot of inorganic or mineralized material. In fact, it's 96% inorganic. So lots and lots of hard tissue inside of enamel. It is made up of hydroxyapatite rods. So anytime you hear the word rods, you should associate that with enamel. And it's what gives the tooth the white appearance. And so this is also what can, or part of what can pick up stain and can kind of change over time. So we'll talk about that in the future. The dentin is the second layer of the tooth, and it makes up the bulk of the tooth. It is underneath the enamel and the cementum, and we'll talk about the cementum in just a second. It is the next hardest portion of our tooth, and it is 70% mineralized. Inside the dentin, we have all the dentin tubules, which is where the fluid can kind of flow in and out into the pulp from outer portions of the tooth. And so anytime you see the word tubules, you'll want to think dentin, okay? The dentin is much more yellow in color than the enamel. And so if you see wear on a tooth and the enamel is starting to kind of thin, then you'll see that yellow dentin shining through. And so you can know what to expect with that. Typically, though, in a natural healthy tooth that has no wear, no fractures, no nothing, you're not going to be able to see the dentin because it's that second layer of the tooth. Next is the cementum, and it's about 50% mineralized. This is the outer layer of the root of the tooth, and it's kind of a dull yellow color. And similarly, with the enamel, which I didn't say, but both the enamel and the cementum get really thin at the CEJ. So when you look at this picture here, you can see up here where the cusps are, the crown of the tooth, the enamel here is really thick. And as you get closer to the cemento-enamel junction or the CEJ, it starts to taper and get thinner. That same thing is occurring with the cementum. It's really thin here, and it does get a little bit thicker as you go along. It's just not as thick as the enamel. And then the inner workings of the tooth, where the nerve and the blood vessels are, is obviously our pulp, and that's what gives our tooth its, function and all of that. It's important to talk about anatomical crowns versus clinical crowns because that will be important for us for coronal polishing. And so the anatomical crown is the portion of the tooth that is covered by enamel, whereas the anatomical root is the portion of the root that is covered, or the portion of the tooth that is covered in cementum. And so that delineation between those two things is the CEJ. So the clinical crown stops at the CEJ, and the clinical root will begin at the CEJ. I hope I said that right, because I feel like let me just repeat that. The anatomical crown will stop at the CEJ, and the anatomical root will begin at the CEJ and go to the apex of the root. I feel like I saw the word clinical and I might have said that out loud. So if I goofed, ignore that. The clinical crown, though, is everything that is visible when you look at the tooth inside the mouth. So if there is some recession, as you can see in this picture, there's a little bit of recession. And I can see the cementum, which is that duller yellowish color shade of tooth structure. This entire thing is now my clinical crown, okay? My clinical crown has gotten larger because I have more of the tooth visible inside the mouth. My clinical root has gotten shorter, okay? So we don't necessarily need to talk about that, but the general thing that you need to know is the difference between anatomical crown, which is covered by enamel and stops at the CEJ, versus the clinical crown, which is everything that's visible in the tooth. So if you have recession, then your clinical crown is going to get larger. I wonder if you can kind of like piece together, like critically think, when a patient would be likely to have more or a larger clinical crown in their life? Can I give you a couple seconds to kind of think about that? So as we age, we might be more susceptible to various things occurring. Our bodies are getting older, and we only have this one set of teeth, and we are constantly using them to eat, and we are constantly brushing and flossing and doing all of the things. But over time, a lot of times what happens is we do get a little bit of recession, or in some patients' cases, they get a lot of recession. And so we see that a lot of times with older adults, more recession with older adults than we do with younger adults. And so that just might be a clinical piece. You might have more tooth to coronal polish because there's a larger clinical crown as your patients get older. Okay, so continuing on with our dental anatomy review, we have contours of the teeth. So we might talk about like line angles and how we roll around from one surface of the tooth to the other surface of the tooth. We have cusp tips that are, convex and then concave surfaces. So all of those different pieces of the tooth that are kind of rolling around, and those are the contours of the tooth, and we're going to have to work around those when we do our coronal polishing. And then the contact is where the tooth comes into contact with the adjacent tooth. And so this is important to pay attention to when we're coronal polishing, because the position of the contact is going to alter how we might hug into those interproximal surfaces a little bit when we're coronal polishing. So the contact is super important because this is going to stabilize the occlusion, and it kind of prevents that food impaction right on top of that height of the papilla there, protecting that papilla. And so for the gingiva, if you just kind of like look at these two pictures, hopefully you can appreciate that one looks a little bit more stable, a little bit more healthy. The one on the right side versus the one on the left side looks really irritated, inflamed, red, bulbous. Just again, it's like one of those things where you like look at it and it looks like it's going to start bleeding. So it's important to pay attention to this when we're coronal polishing. Some of those things that I just talked about, but also even in this one that looks a little bit more healthy here on the right, I hope that you can appreciate that the clinical crowns are a little bit larger because we have some recession here. And that's going to be something that's going to play into our decision-making process as far as like when and where to coronal polish. So the gingiva is all of that soft tissue that's surrounding the tooth. We have a little bit of a sulcus, hopefully little, if they're healthy, which is that space where the gingiva is surrounding the tooth, and it's kind of that free gingiva portion where the probe will fit down inside of. And that's also where the bacteria, the plaque, the calculus all likes to hide. So as I kind of alluded to, somebody who looks, kind of like this picture on the left, we might want to be cautious with our polishing because we can really irritate those tissues and cause them to bleed, which then also might put them at susceptible to that bacteremia. So we just got to be careful. And then again, that gingival recession, which is causing these clinical crowns to be a little bit longer. The recession is showing root structure, which is covered by cementum, which is less mineralized than enamel. So it's not as hard. And so we just really need to be protective of that area of the tooth. Okay, more oral anatomy review. So this time we're going to be talking about the salivary glands. This is really important because it provides the moisture for the mouth, and it also provides kind of like a place for all of the plaque and calculus to kind of travel around in the mouth. And we have major salivary glands, including the submandibular, which is the ones, sub means below, mandibular is the mandible or the jaw. So they're the ones that are a little bit further down. And then we have sublingual, which are these ones that are a little bit further forward. So sub, below, lingual, tongue. So right up here, right underneath almost your chin-ish area, okay? Those spit out of a little duct called the Wharton's duct, and they provide about 70% of the saliva, so a whole bunch of saliva. And every time I think about this, I always think about like middle school, and when I was in middle school, it was like really common for people to gleek. And I hope that I'm not like showing my age, or maybe you all remember this, but like it's where I don't know how they would do it, but they would like manipulate this little Wharton's duck to spit on command. And then they would like spit on people. And it was always so disgustingly gross. But what they were doing, however they were doing it, they were making the saliva come out of that Wharton's duct. But for dental purposes, 70% of the saliva comes from there, and it's sitting right behind these lower anterior teeth. And so, oftentimes that's one of the places where we'll see the bulk of the calculus and plaque forming. And so that's just important for us as dental professionals to know. And then the next one is the parotid gland, which is going to be up by your maxillary molars. And you can see that in the depiction too. And this produces 20% of the saliva, so another good portion. When you look intraorally, the Stenson's duct is, usually right up there next to like your maxillary first molar region. And it's usually covered by like a little soft papilla. But sometimes those can be like all kinds of crazy. I had a student the other day say something like, there's something in the buccal mucosa and I'm not exactly sure what it is. And I looked and it was just a humongous, papilla over top of where that Stenson's duct spits out. And so sometimes they're really tiny, you can't really see them, and sometimes they're really big. But as long as you know where they're at and what to expect, then hopefully it won't be something that will cause you to be concerned. So the next thing we're going to do is we're going to talk about the 4 different types of deposits that you guys might come into contact when you're coronal polishing, some of which we can remove with our coronal polishing, and we should, that's our job, and some of which we should not, because that should be removed with scaling. And so these next few slides, when I'm talking about the types of deposits, it's super important for you to understand what they are, how to describe them, if it's something that you can remove with coronal polishing, if it's something that you can't remove with coronal polishing. So take a few minutes to pause the slide if you need to. Pause my presentation and just kind of read through the slides if you would like. So the first one is the pellicle, and it is the really thin, clear, kind of tenacious-y film that is found on the teeth. And so it's kind of the thing that makes your teeth feel a little bit slimy. Usually following a cleaning, your teeth feel glassy smooth, and then over the next, hour or so, you can kind of start to feel that build back up. And so that is the pellicle. It's made up of saliva and sulcular fluids. Forgot my word for a second. Sulcular fluids. It starts to form, pretty much right away after removal. But we can, as a patient, we can usually start to feel it within about an hour or so. The great thing about this is we know that inside of our oral cavity, the environment is constantly changing in pH as we eat, as we drink different things. And so this is just a barrier to protect our teeth. It also is a great place for plaque and calculus to adhere to, because our teeth are naturally kind of slippery, but this makes it a little bit of an attachment place for that plaque and calculus to adhere to. The next is the biofilm. And so this is what you can feel when your teeth feel like really fuzzy. Okay, so if you have children and you're checking their brushing, I do this with my daughter all the time. I'm like, take your fingernail and like scrape your tooth and let me see. And if you can see it on there, that is the plaque biofilm that we're going to be wanting to remove with our coronal polishing. So it is an organized mass of sticky matrix, and my friend likes to call it sticky bug poop, because we always tell our pediatric patients that we're removing all of those sugar bugs, and so the plaque biofilm is like the sugar bug poop. Okay, so if you want to kind of like think about it like that, it's a little gross, but kind of makes sense. So it attaches to the tooth, and it can cause caries, gingivitis, periodontal disease, especially if it's sitting like right along the gingival margin, and it causes your gingiva to have a response. It starts to get inflamed. You might have some bleeding. Those types of things might be in the gingivitis realm. If it stays on there for longer periods of time and the inflammation process continues, then it can lead to some bone loss. aka periodontal disease. We're also going to talk about later on in this first lecture about demineralization, which is caused by that plaque sitting on the teeth for extended periods of time, and it kind of just starts to break down the enamel. And so that's the start of a cavity. And so this plaque biofilm really is a nuisance that we need to be educating our patients about how to remove, and also that we need to be taking care of when we're doing our coronal polishing. So patients will be removing this every single day when they're doing their brushing and flossing, and usually it builds back up over 12 to 24 hours. And so encouraging your patients to brush 2 times every day is extremely important. Somebody told me this thing, and maybe you've heard it before, but I always ask my patients, how often do you brush? And if they say 1 time a day, then I'm like, okay, do you brush in the morning or brush at night? And they usually always say the morning. Sometimes they say night, but usually always they say the morning. And I always say, oh, somebody told me this silly thing one time. They say, brush in the morning to keep your friends, brush at night to keep your teeth. And it's so true because, oftentimes if we don't brush at nighttime right before we go to bed, we have all of that leftover plaque, food debris, all of the things on our teeth. And then we go and fall asleep. And I don't know about you all, but I'm sure I wake up all the time. My mouth's wide open, my mouth's all dry because I've been, sleeping with my mouth open. It's so dry in there. And that's the environment in which, caries loves to grow. And so it's really important to encourage our patients to do that nighttime brushing. Like if you're only going to brush once a night, you really need to do once a day. You really need to do it at nighttime. But pretty please with a cherry on top, please brush twice a day because it's really important. I try not to like berate them about it, of course, but sometimes if you can make a little bit light, like I had a patient the other day that he was like, thank you so much for not beating me up about that because I know I need to do it more. And you just put it in a nice way. So sometimes if we kind of make a little bit light of a situation, they might be a little bit more receptive. Okay, so calculus is the next thing we'll talk about. This is that mineralized plaque that cannot be removed with coronal polishing. It must be scaled away. It is hard and calcified. It is stuck onto those teeth, and it has, taken a while to build up. It's not just going to show up in one day. It is building up after repetitive inability to remove the plaque. Okay. It's often covered by a layer of plaque or stain. You can see in this picture that it kind of has a brown tinge to it. Typically, calculus is more of like a yellowish color, whereas this one looks a little bit brown. That's because it's picking up stain, which makes sense. The calculus is like rough, and so things are going to stick to that a little bit easier. So the fact that stain is on there is super common and not surprising. Again, this cannot be polished away, and your dentist or your hygienist should be removing that calculus before you ever have this patient in your chair. So just make sure that that is the order in which you guys are seeing patients. And then finally, our last deposit that we're going to talk about is material alba, and it really is just icky. It is that a lot of it's just leftover food particles, kind of cottage cheesy. Sorry if you don't like cottage cheese because that might just put something gross inside your brain, but it is soft bulky mass that's white to yellowish. You're going to see it look kind of bulbous on the tooth. It's going to look like little clouds on the tooth or in between the teeth. You can see in this picture all along the gingival margin, filling this space in between these lower incisors. But it is an accumulation of materials and bacterial growth, unstructured living, and dead microorganisms. These are not things that just appeared today. It is something that has been growing and breeding day after day on the patient's teeth. So now in patients like this that have this material alba, it is extremely, I want to make sure I have all my things. Yeah. There we go. It's extremely important to have a conversation with your patient or their caregiver, because oftentimes when patients present like this, they might not have the ability to care for themselves appropriately on their own. And so maybe their children who have caregivers, or an elder adult who might need some additional help from a caregiver, or for some other reason they need some additional help. And so these kinds of conversations might be happening with the patient, or it might be a combination of the patient and their caregiver, or the caregiver alone, really instructing them how to brush along the gingival margin and how to clean in between the teeth. And in a future lecture, we'll talk about like all of the different types of products that you can recommend to your patients. So it's important to know that this is definitely something that's just not forming, after one day of missing their brushing. Okay, so this is constant repetitive missing. A great thing that you guys can utilize for patient education is disclosing agents. And I understand that many offices aren't using disclosing agents. At the college, we have our students do a plaque score on all of their patients to kind of use more of a teaching tool for the student so that they know where to go and what they need to be removing. But it is fantastic for patient education. And I would encourage you all to, consider talking to your offices about getting some type of disclosing agent, because it really can be really eye-opening. Like, nothing is better than having your patient take a second to chew up some disclosing agent, handing them a hand mirror, and then having them look and see like, oh, wow, I really am not doing such a good job. So this first one is the one that we're going to be using in the clinics when you guys come for your in-person, and it's the most common and widely used. It can be in like a little, almost like a little soy sauce packet is kind of what it looks like, but it's thinner, and it's like a little liquid, or you can, and those are like individual ones, or the one we have is like a big bottle that will kind of drop off into a little dappen dish, or they have those tablets that you can chew up. It's not my favorite type of texture inside my mouth, so I don't really love those, but it's fine. So in this type, it will stain the plaque a like pink or a dark red, and so you can see that in that first picture. The next one is actually clear to the naked eye. And you apply it on the teeth, and then you have to use a special light in order to be able to see that show up. So that's kind of nice for patients who don't want to have their teeth stained, but theoretically you're removing all of that plaque and stain before your patients leave. So really the fact that you can see this first one shouldn't really matter, because you should be removing all of that before your patients leave. But this one's kind of a fun one, especially if you are in a pediatric office, and kids might think that that's kind of cool, even though we're trying to get them to do better. But this last one, this two-tone disclosing agent, is kind of really cool, because you can see that some of it's showing up that pinkish hue, some of it's showing up that blue kind of color. And what that's showing is that like light pinkish red is like thin plaque that may have just popped up there today. But that blue stuff has been there. It's thicker, and it's been left behind on multiple days or whatever. So when your patients are like, because they always are, oh yeah, I didn't have time to brush today, or I was running out the door, or I had lunch, or whatever, that's all well and fine. And we would anticipate for you to have more plaque if you ate on the way here today and you didn't have time to brush. Like, I get that. But then you would be able to explain to them, well, I hear what you're saying. Thank you so much for explaining. That's what all of this pink stuff is. But this blue stuff, that is actually thicker plaque that takes a couple of days to form. And so that's showing me that these are areas that we just might want to kind of dig in and discuss how to improve your brushing or interproximal cleanings in between there on a daily basis. So I think that can be like really eye-opening for your patients. For disclosing agents, it's really important that they have, certain types of properties in order for them to be effective. And so we definitely want them, obviously, their whole purpose is to stain the plaque a certain color so that you're able to see what it is that, like, where the plaque is located. We don't want it to be able to just rinse away immediately, because we want to be able to utilize that for our patient education. And then hopefully it has either no taste or a pleasant taste. We don't want it to be foul because then none of your patients are ever going to want you to use it on them. And then we definitely don't want it to be irritating to the tissues. So all of those are important properties. So we'll kind of switch gears here and talk a lot of it about dental stains. And so stains are just discolorations of the tooth, and they can be caused by all kinds of things, including food, bacteria, tobacco, metals, medications. I can just read my list, but so many things. And we're going to talk about where all of these fit in relative to what caused the stain, and is it inside the tooth or outside the tooth? So kind of the first step of that is to talk about some definitions. And these are sometimes a source of confusion for students when we first start talking about them. So again, this might be a great time for you to just like pause my talking and look through this list, kind of process through what each one of these terms means, and then start my lecture recording again, and I can kind of talk through them, or do it vice versa. Either way, but you should just be really familiar with these kind of before we get started talking on the next slide and beyond, so that you're familiar with the lingo here before we start talking about each one of them and what types of things are these types of stains. So the first way that we can describe stains are based on the location of the stain. So intrinsic means that it is located inside the tooth. So that one's kind of easy to remember. Inside, intrinsic, okay? Extrinsic means that it is located on the outside surface of the tooth. And so extrinsic staining are going to be the types of stains that we can remove with coronal polishing. But if it's inside the tooth, then we're not going to be able to remove it with coronal polishing. And we'll have to talk about some other treatment options in order to be able to address those types of stain. The next two terms are about the origin. So where did the stain come from? Is it exogenous, meaning it originated from outside of the tooth? Or is it endogenous, meaning it came from inside the tooth or the body? And so sometimes, we can kind of cross match the location and the origin. It's not like this one always goes with this and this one always goes with that. So we'll talk about, like I said, those examples in the next few slides. So again, if it's still a little bit confusing, go ahead and pause, read through this again. If you need to rewind and listen to me speak about it again, then that's totally fine. So the first type that we're going to kind of dive into a little bit more detail are the extrinsic dental stains. Okay, so extrinsic stains are on the outside of the tooth, and that is what we can remove with coronal polishing and or staining or scaling, depending. So we'll talk about that too. Exogenous in origin, so that could be, X meaning outside. So they adhere to the pellicle, which is that thin layer, that thin filmy type deposit, the calculus, that hard mineralized deposit, or soft deposits like the plaque and the material alba. Okay. Again, stains don't cause inflammation or decay. It's just an aesthetic concern. So the stains themselves are not going to cause the disease, okay? But we want to make our patients happy. So various types of extrinsic stains. We're going to start with yellow stains, and surely this picture has been doctored because I have never seen anybody with yellow teeth quite that bright before, but I guess there's always a first time for everything. But yellow stains in particular are associated with poor oral hygiene and that plaque accumulation. And typically they're like yellow to light brown, and they're most commonly found on the buccal surfaces of your maxillary molars and the linguals of your mandibular incisors, where those salivary glands are constantly spitting onto the teeth all of the time. Okay, so I remember my colleague telling a story about like the worst yellow stain that she has ever seen before. A patient sat down, and they had so much plaque that, like, she was a hygienist, so she was like scaling it. And she was like, it was like peeling off layers of onion, like how you have like oh, there goes a layer. Oh, there goes a layer. And so just like layer after layer after layer in order to get all of that plaque biofilm off. And so sometimes it might be that they just have so much plaque that you need to polish before, you as a hygienist, me as a hygienist would go in and scale. So maybe if somebody presented like this in my chair, and I had a coronal polisher with me, I might say, I'm going to go ahead and coronal polish first, then I'm going to scale, but they might need coronal polishing again afterwards. We just kind of got to get some of that kind of taken off of there. So that always is an option too. Black line stains, so you can see that in this picture, kind of right along the gingival margin. Sometimes it's right along like line angles too. Um, so this is a type of chromogenic bacteria, or chromo meaning color. And like I said, it's kind of a thin line along the gingival margin. And oftentimes it is associated with some type of iron in the saliva, and it's oftentimes seen in females and not necessarily related to poor oral hygiene. So this is not one of those types of stains. It is going to require scaling, and so hopefully you won't see these types of patients in your chair, because hopefully they would have already been seen by the dentist or the hygienist in order to have that most of that stain removed with their scaling first, and then you'll come in and you'll do your polishing after that. I wish that I wouldn't have had the title in there so that I could have paused and been like, what do you think that this stain is? Because this is like a telltale type of stain. If you know a smoker, or if you have any patients that are smokers, then I'm sure that you've seen this type of stain, this tobacco stain. It's from the tar that is produced from the cigarette smoke. And all of that, those little bits of tar kind of just fill in the pits and fissures and inside any like little enamel pieces that might be missing within the surface. And typically, they're extrinsic stain, but if they are left there for an extended period of time, they can kind of like leach into the enamel and become intrinsic. And if it does become intrinsic, then we may be able to do help the patient remove the extrinsic portion, but they might need to do some alternative treatments in order to get it back to where it was, to remove the intrinsic staining. And again, I know from experience with scaling, this feels like really sticky, like tar. And so this oftentimes will also need to be scaled before then you're just kind of like touching up with the polishing to get rid of whatever the scaler didn't get rid of. The scaler could get rid of everything, but that is, a lot of time to be able to do that. Oftentimes, if you can break it up and get the majority off, then the coronal polisher can get that last little bit. All right, moving on to more extrinsic stainings, but this is like the brown staining. This is oftentimes related to food or beverages that we eat. So think dark wines, dark berries, like blueberries, blackberries. My kids are kind of bad about this because they eat so many berries, even more so than me, but I love a good berry. Soda, coffee. I always tell patients, like, I'm not going to tell you to stop your coffee habit, but try to drink it in the appropriate way. So really quick with meals and not sipping on it all day long, but I could never tell anybody to give up their coffee. I don't know about you. Teas, and anything that is just dark, might leach into the tooth and cause these types of brown staining. And again, these oftentimes will require some scaling, and then polishing to follow. These types of brown staining can also be caused by medications. So chlorhexidine is a great mouthwash that we oftentimes prescribe for patients who maybe have gone through some type of periodontal surgery, or somebody who is going through scaling and root planing, that we just want to kind of like cut back all the bacteria. The problem with it though is that it does cause this brown staining. And so oftentimes we set like a limit of time in which we want the patient to then discontinue use. So it comes in this huge bottle, but never get through all of it before like their time limit is up. So sometimes patients will continue to use it and then you'll see more of this brown staining. So it's a great product. So we're not going to stop recommending it. And since stain is just aesthetic, yeah, patients might not love it, but at least the goal of the mouthwash is to decrease that inflammation, decrease that bacterial load, decrease the bleeding, and it does a really good job on that. Stannous fluoride is a fluoride that is found in some types of toothpastes, and it is a great fluoride to use, but it can cause staining. And then also extended antibiotic use. So patients who might have several rounds of antibiotics, you might start to see these brown stainings too. So we'll need a little bit of scaling before then we can move on with the polishing. More extrinsic stain. These are green stains. So again, this chromogenic bacteria that's causing a coloration. It can be like light green to dark green to yellowish. It kind of has an array of colors. And it's most frequently found in children and kind of right along that gingival margin. And also it needs light to grow. And so we usually find it like in the anterior zone where light can get into the mouth. You can also see it on the posteriors too. It just usually is more readily available to grow in the anteriors. That this picture here on this slide looks way more intense. It looks like a much heavier case than on these pictures. You can see that it's a little bit lighter. It kind of almost looks like striated in some areas, just kind of like pieces and parts, not kind of like all along the gingival margin like that last one. But the thing with these green stains is that you have to be careful because a lot of times they are associated with areas that are demineralized. And so that's when the enamel starts to break down. And it really is that early sign of a cavity. And so if we go to town trying to get this stain off with our scalers as hygienists or with horse paste as coronal polishers, then we really can cause extended damage to the tooth and to the enamel, in which that's never our intention. We would never want to do that. And so if you notice this, just be aware of that. And then just be careful, making sure that we're using a fine polishing paste and also, just lightly polishing around. And we'll talk about all of the specific techniques on how you're supposed to polish here in a bit. You may use hydrogen peroxide or other bleaching agents to kind of help tease this off, since we can't really get too aggressive with our scaling or with our polishing. Okay, and then again, another chromogenic stain. These are orange stains. And so not as common as some of those other stains that we just talked about, but it is similar to the green stains where it needs light to help grow. So oftentimes you find it in the anterior zones, and it's related to poor oral hygiene. And so it's very similar to what we just talked about. My friend told a story one time where she was thinking that maybe the patient had like orange stain like this, and but there wasn't really any reason for that. And so she talked to it was a kid, talked to the kid a little bit more, and he was like, "Oh, I just had Cheetos on my way in." She was like, it was like all over the place. She was like, I should have known it wasn't quite that, because it was like even like outside of his face and everything too. So that's kind of funny. But okay, so I kind of talked about the demineralization process. And so you can see here on this picture, like this is like a telltale, like a very normal illustration of demineralization. So you can see it right along the gingival margins, kind of like a little like scalloped line where the tooth is starting to break down. So this is from that plaque sitting on those teeth for extended periods of time and just the acidity breaking down that tooth, breaking down the enamel there. So these are often called white spot lesions. Again, they're normally in that cervical third of the tooth and they kind of look chalky. They can also be right around the ortho bands or brackets. So I know my sister, when she had braces when she was young and never good about brushing her teeth when we're young, And so even like to this day, I know on like 7 and 10, she has like little squares on her teeth, which of course she hates. Nobody loves that. But that's just from plaque sitting right along those ortho bands and causing that demineralization. So that's unfortunate. But if we experience, like if we see this on our patients, then oftentimes it will feel kind of like soft or rough. It's not going to feel like glassy smooth like the enamel feels. And so if it feels like that, you have to be really careful because you can flick that enamel right off with coarse paste or an instrument, and then it's a cavitation, and then we're going to have to restore that tooth. The best thing to do is to recognize it. Um, Talk to your patient about updating their oral hygiene in this area, and then recommending things to remineralize that area. And so things include like fluoride, of course, MI paste, um, fluoride varnish, any of those types of products, either in office or at home, that the patient can do to remineralize those areas. The one thing that's kind of unfortunate is that it'll still look like that even when it's remineralized, but it will be hardened again, and so it'll go back to feeling really smooth, and it'll be tough, and so we can go back to scaling it eventually. It'll go back to not being as much of a plaque trap as it is right now when it's all rough. So less things will stick to it. So that's our goal, is to remineralize these areas of decalcification. Okay, so we're going to start talking about endogenous stains. And as a reminder, those stains are located, or endogenous are stains that are created from or originated or caused by something inside the tooth or inside the body. In this case, we're also talking about intrinsic dental stains. Okay, so things that are stains that are inside the tooth. So this first picture up here, this is classic tetracycline staining. The tetracycline is an antibiotic that is not as commonly used in patients who are pregnant or young children with teeth that are developing here in the US anymore, because it causes problems like this. And it's just not an aesthetic look. And so, patients don't want that, of course. And so here in the US, we've kind of discontinued the use of tetracycline, although it's still a really great antibiotic, and other countries still utilize it, even though it does cause this staining. And so you might see patients from other countries or older patients that might have this tetracycline staining, but patients that are like 50 or less that are from the US, you're probably not going to see this. But it's kind of interesting to me, at least, because I talk about like primary tooth development as part of my course. It's kind of interesting to see where the stain is at, because then you can really tell like at what point during the tooth development was this antibiotic given, because that's what portion of the tooth was being formed. The portion that's stained is the portion of the tooth that was being formed, when that antibiotic was given. So I think that that's kind of interesting, but not a great look, and something that people don't really want. We can also have these endogenous intrinsic stainings caused by like a high fever when the child was young during tooth development, some type of trauma, like on a primary tooth as an example, that then like butted up into the developing permanent tooth, or maybe a primary tooth got an infection, and then right at the apex where that infection was of the primary tooth, it caused a permanent tooth to get some type of staining on it. Or of course, large amounts of fluoride could cause fluorosis. So that's kind of this picture down here at the bottom. You can see it looks like a little bit white, a little bit pitted. And continuing on, these are like if there was some type of trauma to that particular tooth, like that permanent tooth, and then the tooth died or the pulp died. And so the pulp kind of and the blood starts leaching out into the other layers of the tooth, and it can cause it to look either yellow or brown, kind of like this one, or it can even look darker red or grayish black like this one. Nothing that we're going to do is going to change any of these stainings, right? These intrinsic stainings with coronal polishing. we're not going to be able to alter that, unfortunately, for the patient. But we could always talk to the patients about alternative treatment options. So internal bleaching potentially, other types of bleaching, or, crowns or veneers or some type of restorative treatment. Okay, so now we're going to switch to exogenous intrinsic staining. So stain that is inside the tooth but was caused by something outside of the tooth or outside of the body. So you probably have all seen patients that have older or large amalgams, and the tooth itself starts to kind of turn that grayish color. And that's from that dentin leaching into the dentin tubules and kind of shining through that enamel. And so that would be an example of an outside source, the amalgam, causing inside staining, intrinsic staining. Okay, so exogenous staining, because it was caused by something outside of the mouth, that can be either intrinsic or extrinsic, includes like metallic stains. And so extrinsic meaning that it is adhering to the pellicle and it's adhering to the outside of the tooth, but intrinsic is when it penetrates the tooth. And so the cause is from either metals or metal salts being inhaled. And so this is oftentimes from patients who work in like an industrial type job. And it can be an array of colors, greenish to bluish or brownish if it is like an something where it was like iron dust or iron medications. And so taken orally would be like an iron medication, and that would be more of like a blackish kind of stain. All right. More endogenous staining, endogenous intrinsic staining. And so these two pictures are congenital problems. So patients were born with one of these two conditions. The top one is amelogenesis imperfecta. So something wrong with the enamel. The enamel's not perfect. And then the bottom one is dentogenesis imperfecta. So something's wrong with the dentin. It's not formed perfectly. And so you can see the teeth are kind of yellowish brownish color, or in the dental one, dentinogenous one, it's more of like a grayish kind of staining. In the amelogenesis, the enamel looks like pitted, or sometimes it's just missing. With the dentin, the enamel is kind of translucent, it's really thin. And so in both of these cases, you want to be extremely careful and cautious because the enamel can, flick away, and these patients might be sensitive. Continuing on, we might have genetic hypoplasia or hypomineralization, like low, not as below normal mineralization. So these white spots will be a little bit softer. Again, we want to be cautious around those. And then this is another picture of fluorosis where the enamel kind of looks a little bit pitted, and you can see that those kind of white spots throughout the tooth. We'll kind of shift gears here a little bit and talk about the polishing paste. And we're going to go into detail about all of the specifics on technique, but it's important to talk about like the abrasive agent. And so you kind of want to think about this like a body scrub or like an exfoliant for your face, or you can think about it if you like to, do wood type things like sandpaper. So sandpaper that is more coarse is going to be more rough, and it's going to wear away the wood in that case faster, at a faster rate. So less strokes it will take in order to wear the wood away. Well, that's going to be the same thing when it comes to the polishing paste. If there are more abrasives, meaning it's more coarse, then it's going to abrade the tooth more readily. So that's something you want to keep in mind. The speed of the application. And so we want to keep our either our electric handpiece or our air-driven handpiece at a setting of less than 10,000 RPMs. So when you come to the college, in the lab and in the clinic, we're going to be using electric handpieces. And what's really great about that is you just set the setting for 10,000 RPMs as an example, and then you can push the rheostat all the way down, but it will never go faster than 10,000 RPMs. Whereas if you guys have air-driven handpieces in your office, then you'll have to be paying closer attention to what it is that you're hearing, because that's going to kind of give you the cue on if it sounds more like a slow speed handpiece, which is what we want because we want the speed to be below 10,000 RPMs. Or if it sounds like that real high pitched noise, like a high speed handpiece, that's what you do not want, because you don't want the abrasives to be used on a really high speed. And then the pressure of the application is also a factor. So again, if you're pushing really hard with that sandpaper, you're going to increase your amount of abrasiveness. You're going to wear away that wood or smooth up that wood faster than if you were kind of going slower, I'm sorry, applying less pressure. And that would be the same thing with our polishing pastes also. Some negative effects, so we kind of just talked about, like alluded to them, but excessive polishing can damage the tooth. So if we polished every single day, that wouldn't be good for the tooth. And so we don't want to overdo it. Also, you want to use the finest polishing paste that is appropriate. So trying to use fine paste all of the time is ideal. And so if your office is in the practice of using coarse paste all of the time, that might be a good conversation to have with your office manager or whoever does the ordering to start buying fine paste more often. Exposed cementum or dentin can be damaged more readily. So we talked about how those two types of material or two types of tooth structure are less mineralized, and so they can be damaged quicker. And so you want to be really cautious when you're working around those, and really make sure that you have a light pressure and a slower speed in those areas. And then, of course, as we discussed, the demineralized areas are weaker, and so they can be affected more quickly, and you can cause damage. So you got to be really careful with those. Also, as we are discussing speed and the fact that we're using an abrasive agent, that can cause friction up against the tooth. And so when you're polishing at high speeds, or you keep the polisher on the tooth for an extended period of time, it can heat up and cause the pulp to be damaged. So you got to be careful with that. And then tooth sensitivity can occur, especially in the cervical area where the enamel is thinner, or if you're on the root surface, that obviously is a area that the tooth is a little bit more sensitive because the cementum is softer. And so you want to be careful not to cause any irritation of the tooth or be too aggressive in that area. So again, you really do not need coarse paste, and really that coarse paste can cause tooth damage. So I would encourage you to use fine paste whenever possible. So contraindications for coronal polishing as far as the tooth goes. So we already talked about contraindications based on medical history issues. But as far as the teeth, you want to be careful with newly erupted teeth because they're just a little bit more sensitive, and the mineralization might not be totally complete. So on those, pediatric patients, just be careful. That kind of brings up a point. Oftentimes, there's kind of this misconception that you can only coronal polish children, but that's not true. You can coronal polish anyone as long as they've had the scaling done before they get to your chair. So you might have a 3-year-old that has calculus that needs to be scaled before they come to your chair, and you can't just go straight to coronal polishing. So you can coronal polish any age of patient. It does not necessarily matter, but you do want to be careful for those newly erupted teeth. Restorations, oftentimes, they aren't really super susceptible to getting plaque accumulated on them. And then they're not really meant to hold up or withstand the abrasiveness of our polishing pastes, and because they can just scratch easily. So we don't really need to polish restorations. And especially you wouldn't want to polish a implant abutment as you see in that bottom picture. Now, if there was an implant crown on that tooth and you notice plaque, then yes, go ahead and remove it, because we want to, make sure that we're removing all of our plaque, or maybe you're flossing around that tooth really well. But again, restorations just aren't really intended to need to be polished. Again, areas of demineralization or decay we want to avoid. And then in this kind of bottom tooth, anybody who has really inflamed gingival tissue that is likely to, induce bleeding, we just will really want to be cautious with them, and maybe we should avoid coronal polishing. And then also, if your patient has no stain or has no plaque visible, then there's no reason to coronal polish, no reason to coronal polish them. It's not a benefit other than an aesthetic benefit. So if it's not present, there's no need to do it. This kind of brings me to my next point and my final point of the lecture. Selective polishing is something that you should be considering. That just means that you don't go around and polish every single surface of every single tooth all throughout the mouth. You only polish where it's necessary. And so you want to, again, avoid polishing things that we have already talked about: newly erupted teeth, restorations, demineralized areas, caries, all of those things. You want to avoid those areas, and teeth that don't have any plaque or stain. But the patient's expectation is that this is the cleaning, right? So many times people think that if they don't get their teeth polished, then they didn't get a cleaning. And or if you're kind of skipping around in there, then they might think that you just don't know what you're doing. You're not doing a very good job. So it's really important to have this conversation with your patient as you're doing it, or if you choose to do the selective polishing, and just explain, I don't need to polish here because of this reason. I'm not going to polish here because I don't want to cause damage. It's really important that you improve your home care in these areas so that your teeth can get remineralized. So it's just really important that you have those conversations with your patient. So that is it for this first lecture, and I look forward to picking it up with the next one. Thank you, guys.